Hello everyone. Let's talk a little bit about hypothyroidism.
Sorry, you didn't ask me the examiner question. Can you ask me?
Uh, okay, fine. Uh, right, but it's going to be recorded, or should I stop the recording?
It's okay.
Okay, good. So, Dr. Hiba, excellent performance, and let's just ask the examiner questions. Can you present this patient for me, please?
This is Mrs. X, 32 years old, came with fatness and fatigability and weight gain, constipation, hair fall, menorrhagia for 3 months after bleeding after delivery. Uh, Also, she has dizziness when she stands from sitting position, and on examination she has bradycardia and posterior hypotension. She has low temperature also. She has a yellow complexion and buffy eyes, swelling around her eyes. Um, That's proximal myopathy and positive delayed ankle reflex. The most likely cause of her symptom is Sheehan syndrome and hypopituitarism. Uh, Also, we can put primary hypothyroidism, postpartum hypothyroidism, but the presence of posterior hypertension against that. Uh, I think that.
And how are you going to manage this patient?
Okay, I will admit the patient. I will do
Before
basic
that,
blood.
yes, yeah,
Mhm.
go ahead.
I will do basic complete blood count to see if she's anemic. Inflammatory markers, liver function test, and RT, TSH, T4, T3, and thyroid antibodies. Also, I will check short synaptin test. I will see full hormonal profile, FSH, LH, and prolactin level. I will do image to visualize the pituitary gland, and I will also do image to see the thyroid scan, MRI pituitary, thyroid scan.
Okay, and treatment.
Treatment, education counseling, non pharmacological, education counseling about the disease, and hormonal replacement, giving thyroxine, giving uh, cortisone.
Fine, yeah. So, as I told you earlier, we have to give to replace the hydrocortisone first before
Yes.
the thyroxine to avoid adrenal crisis precipitations.
Okay. Mhm.
Excellent, well done. And
Thank you.
multidisciplinary teams, including the endocrinologist.
Sorry?
Multidisciplinary teams, including the
Yeah.
endocrinologist. Yeah, to take care over the care of this patient. Well done. So now I need to I think is very well presented and very excellent medical knowledge. I don't need to add anything, but I need to just to speak a little bit about hypothyroidism for anyone just to learn in details about hypothyroidism, and I will help you to memorize the symptoms by understanding the physiology of hypothyroidism. Just let me minimize this. Okay, that's used. All right. 1 second. Fine. So we're going to in this presentation, just I'm going to speak about the symptoms and how are they related to the physiology of the thyroxines. The thyroxine play important role in the CNS development. Actually, it plays roles in almost every system in our body, including everything. I will speak about them all. So CNS development, metabolic regulations, cardiovascular functions, growth and development, and I'm going to speak in details about the metabolic and neurological and also in the musculoskeletal systems, cardiovascular systems, in the dermatological system, and also in the gut and in the reproductive system, and hepatobiliary and hematologicals. So thyroxine play an important role in all those, but we're going to speak in details about all of these. So CNS development, so thyroxine play a critical role for neurogenesis, myelinations, and cognitive developments. I'm going to speak into more details as well about all this. And metabolic regulations control basal metabolic rate and thermogenesis, cardiovascular functions, modulate the heart rate, contractility, and vascular resistance. Growth and development is thyroxine is essential for skeletal maturations and bone turnover. So metabolic manifestation in details. The patients will present with fatigue, exercise intolerance, cold intolerance due to reduced energy expenditure. So the thyroxines is or thyroxine deficiency will lead into reduction in the basal metabolic rate, and which is going to manifest as fatigue, exercise intolerance, cold intolerance. And that's why this will be the presenting manifestation of any patient with hypothyroidism. Regarding carbohydrate metabolisms, so the patients may develop hypoglycemic episodes due to impaired insulin sensitivity and decreased gluconeogenesis, and as well as reduce the rate of glucose absorption from the gastrointestinal tract. And also we'll have as a thyroxine play important role in the lipid metabolism. So the patient will also may have hypercholesterolemias and elevated rate of LDL cholesterols, and also will present with weight gain as a result of decreased lipolysis and fatty acid oxidations, despite reduced appetite. So neuromuscular and cognitive effects. In the neurological, manifestations. So the patients will present with lethargy, somnolence, poor concentrations, and memory impairment due to slowing of cerebral functions with decreased cerebral blood flow and glucose metabolisms. And in more critical cases, the patient may progress to myxedema coma, which is profound CNS depression, lead to hypothermia, hypoventilations, and reduced consciousness. That's why, like any patients with hypothyroidism, we need to rule out myxedema coma. So in our examinations, we have to bear in mind if this patient has any reduced conscious levels, we check their temperature, of course, and if they have any breathing problem like hypoventilations, so we need to rule out myxedema because it's endocrinology emergency. In terms of musculoskeletal effect of the thyroxines, so the patient will present with proximal myopathy, which is due to reduced protein synthesis and impaired glucogenolysis in skeletal muscles. So the patients of hypothyroidism will present with proximal myopathy, and this is due to reduced protein synthesis and impaired glucogenolysis in skeletal muscle. And deep tendon reflexes will also be delayed. They may also present with muscle cramps, stiffness, and pain, which occurs in 30 to 60% of patients, as well as carpal tunnel syndrome due to peripheral nerve entrapments. Regarding the cardiovascular manifestations, they will have bradycardia, a reduced heart contractility. They will have increased peripheral resistance, and they will come with some ECG changes. So bradycardia, a reduced contractility of the cardiac muscle due to reduced beta adrenergic receptor density and activity, lead to characteristic bradycardia, and contractility decreases as sacroplasmic reticulum calcium ATPase expression falls, reducing the cardiac output by 30 to 50%. So it's really important in our examinations not to forget the cardiovascular examination, because it's like also red flag and we can't miss it. So we need to, in addition to the bradycardia, we need to check out if they have heart failure or not. And also they may present with hypertension due to elevated systemic vascular resistance. And we will also, in our investigation, we have to do ECG, 12-lead ECG. And in addition to the sinus bradycardia, they may have a prolonged QT interval, low voltage, and non-specific ST and T wave changes. Also, thyroxines levels will affect the dermatologic and mucosal system. So the patient with hypothyroidism may present with myxedema, which is due to accumulation of hydrophilic glycose aminoglycans in the dermis, lead to characteristic non-beating edema, particularly around the eye, hands, and peritibial regions. So patients with hypothyroidism, in our examinations, we have to look to non-beating edema, particularly around the eyes, hands, and the chins in the legs. And epidermal changes, they will have reduced sebaceous and sweat gland activity, causes characteristic dry, rough skin with decreased sweating and increased keratosis. In the hair and nails, reduced hair follicle stimulation result in dry, brittle, slow-growing hair with characteristic lateral third eyebrow loss. And also mucosal changes, and they will have macroglossia and voice changes like hoarseness of voice, and which is result from tissue mucinous infiltrations. And also they play an important role in the low level of thyroxines will result in reduced gut motility, and this is due to result in decreased smooth muscle activity, will lead to constipation in 60% of patients with reduced gastric emptying and intestinal transit. So also one of the manifestations of hypothyroidism is constipations and reduced gastric emptying. Also, the patients, if female, will have oligomenorrhea and ovulatory cycles and reduced fertility due to altered gonadotrophin releasing hormone pulsatility, leading to menorrhagia, oligomenorrhea with anovulatory cycles and reduced fertility. Hepatobiliary effects, so reduce hepatic metabolism, impairs bilirubin clearance and drug metabolism, while gallbladder hypomotility increase gallstone risk. And lastly, hematological effects, low level of thyroxine reduce erythropoietin productions, and ion utilizations lead to normocytic anemia in 30 to 50% of cases. So bearing all these symptoms we just discussed in mind, if any patient presented with some of these symptoms should raise the clinical suspicious of hypothyroidism, and this will prompt us to do further investigations such as thyroid function test and also investigations to look for etiology such as autoimmune thyroiditis, iatrogenic, and congenital causes. And I'm going to speak about it in details. And I'm going to speak in details about different types of hypothyroidisms. Just I will share with you now. Right, one sec.